Yeah, she had a couple bottles. 2, 3? No, you're all done? She has none. She had none. That's why she was so excited while she was giving the breakout session. So thank you guys so much for returning back to us. We've got a couple more sessions before our evening meal or
it's heavy hors d'oeuvres, drinks.
Heavy hors d'oeuvres and hurricanes. So without further ado, I'm going to bring up a gentleman that I just met. Great guy. He told me he tore down a house in Phoenix and built another one with his bare hands in the middle of July, which is quite a feat. Ladies and gentlemen, Joe Helle.
Thank you. Okay, I did not say that, by the way. We're definitely not in July. So my name is Joel Helle, pharmacist by training. Been with the company for 27 years. And I own our relationships with doctors and hospitals and patient support groups. And then over the last year and a half, health equity has become, sort of the buzzword around for everyone. And so I wanted to talk to you a little bit today about sort of what that means to us at CVS Health, at Caremark, at CVS Specialty, and then some of the, services that we've started and some of the things that we're going to do differently, understanding the disparities that are out there. And, I've learned so much over the last 15 months or so in seeing what those disparities are. So I'm not going to read each one of these, but what's important to note is that there are huge disparities out there. And with a company like we are, where we have 9,000 stores and 1,000 minute clinics, we really have, I would say an obligation and an opportunity to help close these gaps. And I think we've realized that we can't do it alone. These aren't easy sort of problems to solve. We're going to have to work locally in communities and do things differently. And by the way, what works in Miami is different than LA, is different than Chicago, is different than Phoenix. And we're spending that time now to really understand what's different and hopefully create different types of programs and not have a one-size-fits-all for everybody type of program, which is why we have the disparities we see today, right? Because a lot of our programs are one-size-fits-all. So, our approach today, in today's world, is first, we got to define, what is health equity? And I feel like that word is used an awful lot out there, right? And so for us at CVS Health, it's really just that everybody has a fair and just opportunity to be healthy, right? Fair and just. And we know that often there are obstacles that get in the way of that. And sometimes those obstacles are where you live, right? And do you have access to healthy food? Do you have access to a hospital? Do you have access to a doctor? Do you have access to housing? And then other times we have to really recognize that things are just about racism and discrimination. And sometimes when I talk about this, sometimes people will come over to me after and said, I feel like you called everybody else a racist. And that's not what I mean at all. Sometimes that's true, right? But other things are just that has been years and years of what's behind it. I'll give you an example. In sickle cell disease, which impacts the majority of black people in the nation, when they go to, terrible pain manifests itself in probably the worst pain that's out there. When many of them go to emergency rooms, pharmacies, other places in pain to get opioids, since the opioid crisis, they're treated terribly, right? In a disease that manifests itself in such horrible pain. So we really have to ask ourselves why. I know when I was in pharmacy school, I got, maybe a day's worth of training on sickle cell, and what I remembered all these years later was very little. And so why, when someone comes to the counter who happens to be black, or someone goes into the ER, and the National Sickle Cell Association said to me, Joel, we tell our patients to dress up nice before you go to the ER. So imagine you're like in the worst pain of your life, and they're telling you dress up nice before you go to the ER, to be sure that security won't walk you out of the hospital because they think you're a drug seeker. So sometimes it's about things like that, and we have to understand, sort of what that's about and why that happens. So we really broke this down into sort of 4 work streams and 4 buckets of work. education and awareness, testing and screening, access to care, and treatment optimization. And so when we think about those four sort of buckets, it gets a little easier to think about what to do next, right? The first part is with who. So we have to start with ourselves, right? Our own pharmacists, our own nurses, our own clinicians, our own people in specialty that are talking to people on the phone every day to make sure they have enough education, information about people that might not be the same as them. We also have relationships with hospitals. We have 9,000 stores that are out there in the country. We have 1,000 minute clinics that are interacting with people. We have an opportunity and an obligation to make sure that, that they get the information as well. I would tell you that every hospital I talk to, every organization I talk to, every patient group I talk to, they all want to work together. And like I mentioned in the beginning, we can't just think we're going to do this on our own. We all have to sort of combine together to really close these disparities, and they're not easy to do. So, that thing is terrible, by the way. Whoever put that screen over there? Let me look at what I'm saying. Okay, so the first that, maybe it's just because I'm old, right? So the first thing we had to do was create a data tool. And I think a lot of times when you Google stuff, you'll see all these companies that are out there saying, we saw this disparity. So it was the first thing we had to do. And we had to decide, do you build your own or do you buy a tool that's out there? So we built our own. And we started with sort of 12 different indices of publicly available data around things like education, around things like access to care, around things like climate, to really understand where disparities are most likely to happen. We're now up to 24 different indices of data that we use to understand where we most likely would see health disparities. And are people going to have access to housing? Are they going to have access to healthy food? And people will sometimes say sort of the social determinants of health, right? So that ability then gives us a map, right? So we'll get this big map, and you can see little red dots for all the zip codes that show where we're most likely to see a disparity. What we can do next, and then, is attach that to our data, right? So Caremark data, CVS data, Aetna data, to see if there's really a disparity. And the thing I've learned the most over the last year is there's always a disparity. It's shocking to me. We look at adherence, medication adherence. We look at gaps in care. No matter what we look at, right, there's always a disparity. And then that area can also separate it by race and ethnicity, right? So we can see that area happens to be 70% black or 30% Latino, whatever it is, and we can get a feel on what is the disparity across race and ethnicity. And again, we always see disparities. So when people live in underserved areas, you can see that the social determinants really do make a difference, right? And I think when I was in college, nobody talked about that at all. Right? I don't think it was something that was ever talked about. It was all about genetics, right? And it was your genetics were going to determine kind of your lifespan and how well you did navigating through the healthcare system. Now I would say this is probably more important about your ability to sort of navigate through the healthcare system. But that's only, part of the story. The second piece is really about real race and ethnicity data. Let me go. Real race and ethnicity data, right? So today, at Caremark, for example, at CVS, at MinuteClinic, we never captured race and ethnicity. So when you kind of sign up and you get your prescription filled, we wouldn't capture if someone's white or black or brown or whatever. We're starting to do that now. And at Caremark, we're starting to ask our clients to provide that data. Then, some things are not about where you live. It's really about the color of your skin and who you are, right? We're also going to collect data like LGBTQ, pronouns, those type of things, right? So we can get better at really understanding what's happening. We recently hired a chief health equity officer. Her name's Dr. Jonee Caldoun, and she's awesome. And my favorite example she uses is that a black woman with an advanced degree is more likely to have a bad maternal outcome than a white woman with a high school diploma. And so what that tells you, it's not about where you live, right? It's not about how much money you have, what kind of job you have, what kind of education. There's something else going on there. I don't have the answer for what that is. I don't think anybody does today. But there's something else going on there so that we can really understand what's happening there. So if I have the race and ethnicity capability in the data, then I can do a better job of doing two things. One is look through underserved areas for things like social determinants, and what can we do related to social determinants? What are the types of things that we can help people with housing or with food? The second is with race and ethnicity, how can we approach it differently? So I was at the National Black Church Association a few weeks ago, and I would say the answer is we need to ask them. And we say, like, within a particular disease, what does this mean? Around COVID, we learned so much around sort of hesitancy of folks in Black, brown communities of wanting to take vaccines. Where do we learn the most? From those communities. And how do people want to consume information differently than we would do today? So a commercial on TV, or your doctor, your white doctor in a big hospital telling you what to do, or do you want to get it from the communities that you're in, like churches? And the National Black Church Association was so, welcoming, I would say, to us to say, like, help us together, instead of telling us what to do, help us together on how we can close these gaps. So the data is the first part, and the who and the where is sort of the second part. So an important difference between kind of social determinants and race and ethnicity data. I would tell you today in EHRs, so if you guys are working in doctor's offices at all, most of the EHRs can capture it. When we look in EHR data, it's not always filled out, right? Some doctor's offices just don't ask for it. At Minute Clinic now, for example, they have Epic. They capture race and ethnicity, so we're able to sort of pull that information out if it's needed. It's an interesting topic because people will ask me things about privacy, right? Is there, privacy around whether or not you can capture it? What I would say is, first of all, it's up to the patient whether or not they want to provide that, right? There's always an option not to do that. And then the second is that there is not a privacy issue related to capturing it any more than there would be what medication you're on, right? The data would need to be treated exactly the same. And if someone has access to an EHR to be able to, for treatment purposes with you, they would see your medication the same as that they would see race and ethnicity, right? And then our ability to use that data sort of to understand the differences will then help us make different treatment decisions over time that might be right, or provide information to patients, doctors, et cetera, about what might be different. So when we think of access to care, I'll do a side note. You might have seen this week that CVS announced that we bought Signify, a company that's out there in the home healthcare space. They have like 10,000 doctors that will come along with them, and they're in the homes of patients. So it's a really different idea. And this really came out of, if we want to be in this sort of space of primary care, we don't want to just have more doctors and be the next one to have more doctors. We want to fill a gap. And a gap is in rural areas, is in white space areas, is in underserved areas where people can't get in their car and drive to a doctor. How do we go to them? And so I'm super excited about it. We're like 3 or 4 days in, right? But I'm super excited about it because I think we can change the landscape of how care is provided for everyone, number one. But number two, how do we make sure as we do this that we're really doing it right for underserved areas and for people in different communities, right? Because for up till now, I don't think we've been doing it right, or we wouldn't see all these big disparities, right? And then, the sort of landscape of a Minute Clinic that can sort of do not really primary care stuff, but the sort of secondary stuff when doctors aren't around, on the weekends, that kind of stuff, vaccines, all that other stuff, along with this sort of primary care in the home. I feel like it helps us to get to a better place to serve underserved communities. So super excited about it. We'll see what happens. All right, I can't read that. Let me look what I'm talking about here. Okay. So the first thing, we had to decide after we had all this data is like, what do we do with it? And our customers, like in the Caremark world, will say, okay, you just told me there's these big disparities. It's your adherence program. like what are you going to do to make it better? So the first thing we're doing is looking at ourselves. Whatever program we have out there, it could be an adherence program, a gaps in care program, any type of programs like that, we're going to look at ourselves first. And we're going to try to make those programs better and different. And I'll give you a couple examples. One is, it can be as simple as things like frequency, how often we call someone, how often. So we're playing with those right now. We have a bunch of pilots going on. It's been super interesting to see that some of this stuff actually works when we actually make changes in particular areas. We talked to the local community pharmacists there for our areas to understand what's different. The language thing is obviously very important to make sure that we're talking to people in the right language, if we're talking to them on the phone about adherence or if we're sending them communications about it. And then, the second is prior authorization, which I know a lot of you probably have an interest in. So I wanted to look at the prior authorization data to understand if we saw disparities within prior authorization. And I frankly was a little bit nervous about it. Like, what if we have this sort of bias in our question sets that somehow makes, black or brown or Asian people not get drugs more often? It's a scary sort of proposition, right? The good news is, when we looked into the data, we didn't see that. The approval rates across race and ethnicity were exactly the same. So the question sets seemed like we're okay. So you might start to say, okay, you're good. The second thing we looked at was how often it happened. And we found this huge disparity in underserved areas where a prescription comes into the pharmacy and it dings and says, needs prior authorization, right? And then theoretically it would be up to the doctor's office to sort of do something to make that happen, right? And then nothing happens. And there was this huge disparity in underserved areas where we would see all kinds of scripts coming in and the person never going on the medication that was prescribed in underserved areas. Very concerning, right? So we sent people out in Miami, in Chicago, and in the Bronx in New York. And we started asking the clinics there and the doctors in the underserved areas, like, what's going on here? And I'll tell you two things. One, it was all over the board. And two is Miami is different than Chicago, is different than the Bronx. So for example, in the Bronx, they said, look, I'm only here once every 2 weeks. So I send the script over, or give it to the patient, and then I'm gone. So I don't even know what happens after that. I don't even know if the patient got it. I just assumed that they get the medication and have no sort of feeling that whether it happened or not. Others are about race and ethnicity. About language, sorry. I get a PA form faxed to me, and it's in English, and all of my staff doesn't really speak English that well, and so they don't do it, right? So it's really concerning. So we started have to build new and different programs to sort of fill those gaps. I think the biggest transformation that can help underserved areas is really around technology, right? So first of all, connectivity into the EHRs has really made a change for us in our ability to sort of pull the information that's needed for the prior authorization out of the EHR and then submit it to the payer for the doctor. When that happens, the doctor doesn't have to be there. So that doctor in the clinic, doesn't need to be there. Well, we need to make extra specially sure that in underserved areas, we're connected electronically into the EHR to sort of take the administrative burden away from those doctors. In other areas where we have translation issues, et cetera, we need to get better at it. And when I say we, us as a company, but also the industry, like we need to get better at our ability to meet the needs of our local customers. So we're already seeing some great results in those three areas I've said, around where we're starting to see just having someone go in there and say, here's what you can do, understanding things like real-time benefit, which I don't know if everybody knows what real-time benefit is, but it can tell ahead of time when you're prescribing what's the formulary drug to write. You can determine what the copay is going to be. You can determine better information. Also, we want you to understand the tools on the other end around things like connectivity, Cover My Meds, other type of programs that are out and available to make these things easier. And what we see is that those areas, those underserved areas, didn't know about those, much more than the non-underserved areas. They knew about real-time benefit. They know about prior authorization. So we have a lot of work to do, I feel like, to make sure that we can do that. The second is about our sort of partnerships with patient support groups. I feel like we've learned so much. I mentioned, sickle cell organization. We went in there, we didn't even have relationships with sickle cell organizations in the past. There's some newer specialty drugs that are out and available now. And when we went to talk to them, they were like, oh my God, we're so glad that someone finally came to talk to us. Let us tell you what the problem is. So it started with what I mentioned in the beginning around people having issues, with opioids, et cetera. There's also, drugs that are available for, if you take it every day, you're less likely to have a crisis in sickle cell. Less than 30% of folks who have sickle cell are on those drugs. And so the question is why? So when you go back to my original set of what do we do, education and awareness, we got to make sure that the patients understand. There's only 23 sickle cell treatment centers across the country. So if you don't happen to live near one and you're going to a primary care doctor who's never really dealt with sickle cell, I'm going to guess that you're not getting the right information. So we have an opportunity to make sure that those doctors understand things like being on hydroxyurea every day and adhering to it is important to not have a crisis. Let me look where I am over here again. Okay, and I mentioned this already, but the who, I think, is what we're really getting better at. I mentioned the faith-based organizations. The local hospitals is a great example where today, Sutter in California, we're doing a pilot with them right now, where we're going to their underserved areas. All they know is they wrote a prescription, right, for a patient in hypertension is what we're doing this. They know they wrote the prescription, and then they're sort of done with it, right, and hoping the patient comes back to their clinics, et cetera. We combine our data sets, and now we can tell that doctor the patient filled their prescription, and then they're adherent or not adherent to their prescription over time. And then if they're not, how do we get out into the community? They actually have community-based people to get to those patients to help them understand, number one, is it a social determinant issue? Can we help you with housing, food, et cetera? Or number two, is there some other issue related to race and ethnicity that we could help you with to get you back on the medication? And even just things as simple as a blood pressure check once a month, right, which just doesn't happen in those areas. How do we get people sort of back on track to have those things happen? Let me look at what I'm saying here again. Okay, so from the sort of testing and screening bucket that I mentioned before, we have these mobile vans. They're kind of like these big white RVs all around the country that are going to underserved areas to do screenings. And I went to one in Phoenix just recently, in South Phoenix. It's a affordable housing area. It was really interesting to go to. So this big white, RV pulls in. It has a big CVS heart on the side, and you could see people sort of looking out the window to see what's coming down. They come down, and this woman said to me, "What's going on?" And I said, "Look, you can get your blood pressure checked, you can get your sugar checked, you can get your BMI checked, and then if something's off, we can help get you to low cost or no cost physician to get help and get support." And she was like, "Oh, well, I didn't even do my hair this morning." And I said, "That's all right, don't worry about it, get in line." And then before you knew it, there was a line of people there waiting for the screenings. As I was going through the line talking to people, I was shocked at sort of how many people did not have a primary care doctor, had never checked their blood pressure, didn't even really know that blood sugar was an important thing to check. And so you start to understand when you think like people are, these disparities that are happening in these underserved areas, why it's happening. And so it's been really exciting to sort of connect and see these screenings as the first start, right? Oh, and the last one I forgot is mental health screening, right? Especially post-COVID, like we know that there's a mental health crisis, in the US today, especially in kids, and these vans are also equipped to do sort of a mental health screening to determine if someone needs to go to see someone else, et cetera. So it's very exciting. We're growing this over time. It's actually been going on since, 2006 or something, but we've gotten much bigger now, and our intent is to get even bigger than that. So very exciting. We also have a relationship with Uber. Transportation is often the reason why someone can't get to their doctor or why they can't get to like they're in sickle cell, for example, get to the doctor, get an appointment, and get your blood pulled to see how your hydroxyurea is doing. We can get you, in our relationship with Uber, to those appointments. We can get you to work. We can get you to a doctor's appointment, a hospital, et cetera. And so those, sort of goals of understanding what's happening local and working with Uber has been super exciting for us as well. When I talk about education and awareness, I mentioned this already, but the getting to local geographies, like in the Bronx, like I told you, understanding what's happening within a clinic, and then going back and understanding what education we can build to bring back out. Sounds really good, right? But what's really hard about it is all of a sudden you might have 50 different programs. So I think the biggest challenge we have right now around education and awareness is how do we be local and still be able to do it everywhere, right? I think the answer is that our tool that shows those little red dots, across the country helps us to decide where's the most important place to go. And the data will show us like the biggest disparities and where is the biggest disparity that's out there, and we'll start there, right? All right, so for specialty, I thought it was important to say in the underserved areas, I mentioned, people aren't getting PAs in some cases. How do we fix that? First of all, we have to make it convenient, right, for doctors and or for patients. So through Specialty Expedite, which is our connectivity into the EHR, we can take away that sort of administrative burden of the prior authorization process. We can do all the work. We'll submit it directly to the payer if the payer allows it. But even if the payer doesn't allow it, we'll send it back to the doctor all filled out so they can send it themselves all filled out. So, our first journey into that was getting connected to doctors. And I think we're connected to about half of the doctor's offices we have across the country now in specialty to do that work for them. And then the other half is, the vast majority of it is a bit about connectivity and what type of EHR you have and do you have Cerner. But I feel like it's getting better, and by probably the end of next year, I think we can be to that sort of 75% number where everybody is sort of connected, and it makes the whole process and takes faxes, out of the process. I can tell you that I went to Apple, and we were talking to Apple about what we were doing, and we were explaining, and I was like, look, about 60% of what we get into the pharmacy today is faxes. And these young kids, they're like, what's a fax? They don't even really know what it is, right? That are building solutions for us about what to do. So we got to get rid of the paper and the sort of administrative burden out of the system. Expedite and connectivity, I think, is the answer to do that. And then Specialty Connect is with the ability to either pick it up at the CVS store or we can deliver it to your house. So I think the convenience thing, we learned, especially during the pandemic, that people want the ability to decide themselves if they want to go to the store or they want to pick it up. And then very recently, we now have what we call Specialty Central, but it's really just status, right? And so believe it or not, 50% of the calls that come into the pharmacy are looking for status, like where's my script, right? And if you could just look into a system and it said to you, all right, we're waiting on financial support, we're waiting to hear back from the doctor, we're waiting for whatever, it would give you so much more information that you didn't have to actually dial the number and sit on hold to get forwarded around to answer the question of where's my prescription. So we just started that, I think, in the last couple weeks, you guys, right? And so we're just starting to connect to doctors and show them how to log into the system to be able to see their scripts. They'll be able to see all the scripts regardless of what a pharmacy is filled up from CVS side. And get that status. And it takes a whole nother piece of kind of administrative burden out of the system, right? So between Specialty Expedite and then Specialty Central, I feel like we really can, change the way care is being delivered. But we got to get people all connected, right? 50%, we need to be at, 80, 90, 100% connected in order to really get good at this. And then the other piece is, even when we're connected, EHRs are all a bit different. There's different tabs, there's different where you put stuff. And we need to get better at standardizing the way data is put into EHRs so that when we go to pull it, it's in the right place, right? Does that make sense? So that it does it automatically. And I think there will be a day with AI where artificial intelligence, not autoimmune, with AI, where a lot of this stuff can happen ahead of time. So if we can see someone is getting Crohn's medications filled or whatever, that it's already looking ahead to say this person might need Humira, coming up. My son has Crohn's, so he's on Humira. And, when it gets to it, it's already approved in the system, right? So you don't have to go through a prior authorization process. And for someone who has Crohn's, the last thing you want to be doing is waiting 14 days to get, your Humira filled. You want it today or tomorrow or the next day. And the ability of using AI to do those PAs ahead of time, kind of a weird concept, right? So that if you did actually need to go to it, it's already approved. And you don't have to go through all this sort of administrative work. Oh yeah, let me read this slide. I'm going to skip these because I just talked about them. And I have 3 minutes. Okay. And then last, which I think is an important one, is sort of our digital tools, right? And this is a bit more on the patient. But, even, I mentioned my son on Humira. Like, even 5 years ago, you had to call the pharmacy every single month. You got to talk to them on the phone. You're going to answer these 6 different questions to get your specialty medication filled before it gets dispensed, and then tell me where you want to send it. Now, you can go into the app, answer all those same questions, decide where you want it delivered, and have it there. It's a huge, takes away a huge burden for people just to even have to make phone calls into the pharmacy. We're now taking that to the next step, where sickle cell is a great example, where we have real digital experiences with patients. So for things like pain, they can answer some questions within the app, sort of like a pain control questions, and they can either talk to the pharmacist through, sort of instant messaging, or just by answering those questions, we would provide that information back to the doctor so that they could see it when they're getting ready to prescribe, whatever's needed next for the sickle cell patients. We've been working with Duke and St. Jude over the last year to build this sort of new app capability. And, I'm really excited to see how it's going. It's just getting launched like in the next month or so. But I feel like that's the sort of future of people want convenience. They want things to be easier, quicker, faster. And how do we let them do it on their phone? And I think we thought that, or maybe I thought, I shouldn't say we, I thought that in underserved areas, people don't have phones, right? And so like all this digital capability, is it really gonna make a difference? What we've learned is it's actually the opposite. For a lot of people in underserved areas who don't have a home and don't have a car, the only thing they have is a phone. And that phone is sort of central to their lives. And our ability to communicate differently and better with folks through these digital assets is what will make us successful. So we're continue to build those. And so I'd say, sort of lastly, this is the beginning of our sort of journey here on understanding equity, right? One is using the data to understand disparities, whether it's sort of social determinant data or real race and ethnicity data. 2 is understanding, what those disparities are. And then 3 is solving them. We're gonna be out, you'll hear, I don't think I'm supposed to talk about it, but I will, shortly here, talking about sort of mental health and heart health. And we're gonna put out some big, bold goals around mental health screenings and around sort of blood pressure control, so that everybody in the company, whether you're at CVS Specialty, whether you're at Caremark, CVS Retail, MinuteClinic, will be doing something to support our patients to work towards better blood pressure control across race, across ethnicity, as well as looking at social determinants. So a lot more work to do. Super exciting. I think in the 27 years I've been here, this has been the most exciting time for me because I feel like we really can make a difference and really can make a change. But at the same time, like we can't move fast enough, for me. So that's it for me. So oh wait, I got to throw in my plug. So tonight at 5 is drinks and heavy hors d'oeuvres, I think they told me. Upstairs, it's here. You go out and to the right. and drinks and whatever. So please come over and have a drink, and I'd love to hear what you guys think about equity and how you guys think about it, because the real learning, I think, comes from me hearing from you, not me telling you guys what you need to do. So thank you very much, and I think I'm back to you.
Joe, pleasure, man. Oh, it's not that. Your hand's not that sweaty. It's okay. Maybe it is. Now, Joel, we're still going to have that breakdance battle later, right?
I'm in.
All right, cool. All right, guys, we're going to keep rocking and rolling. Up next, we have our social media panel.